Welcome. I'm Dr. Randy Martin, and we're here with CTS.net. It's the Mitral Roundtable. I'm thrilled to be joined by a great group of colleagues. Rudiger Lang from Munich. Rudiger, good to see you. My friend David Adams from New York, and also my friend Frank Wells from Papworth. Good to see all of you. So it's a big topic, Mitral Roundtable here. So let's start with degenerative mitral regurgitation, primary MR. Let me ask you, when do we operate on the asymptomatic patient? We know that symptoms are class 1, but I see a lot of patients in my practice who are asymptomatic with severe MR. Rudiger, what do you think? When do we operate on the asymptomatic patient?
I think I would consider operation if you have clear signs of sequelae of mitral insufficiency, like the enlarged atrium, episodes of atrial fibrillation, enlarged ventricle, or even decreased function of the left ventricle.
Frank, what do you think?
Yeah, it's a good place to start from. I think you have to just consider what is meant by asymptomatic. It's a very difficult area.
Right.
Many people like to conceal their symptoms, so once you get through that, you then are faced with patients. The very fit patients often present very late because their physiology can deal with the reduced flow reserves. So exercise testing is really important. But if you start with the structural heart, the dilating left ventricle, certainly in diastole up to sort of 5 centimeters and beyond, and exactly as has already been said, if you've got atrial fibrillation, signs of pulmonary hypertension, and these may develop out of sync with one another as well. So I tend to go through those steps with the patient and then start to build a case and discuss it with them.
David, we know, a great point. David, we know patients tend to minimize their symptoms. So what are your thoughts? What are the triggers?
Well, I'll just add to what Rudiger and Frank said, Randy, and that is, I think severity of MR is really important. And you get when you look at an echocardiogram, I think the first thing you got to sort out is how severe the MR is. Patients that have wide flail gap, for example, holosystolic MR with complete flow reversal, these are patients that are going to, I think, have a poorer course. And I think it's been shown in the literature by Rosenhack, for example, they do have a earlier progression to events, whereas patients that have chordal elongation, mid-systolic leaks, a Barlow deformity with excess tissue, I start before I think about the other symptoms and triggers, thinking about the MR. If the MR is severe, then I start doing exactly what both these guys have said, which is start looking at the other points, making decisions. And as you get near trigger points, paroxysmal atrial fib, or even aware of palpitations, increasing left atrial size, an EF that's fallen, maybe it's 62 or 63,
right.
Not a trigger, it's 60. These are the patients, I think, that make the most sense to do asymptomatic surgery.
And you and I have talked about this, we've all talked about this, that exercise testing, I think, really plays a role in these patients to see, are they truly asymptomatic? What's their right-sided pressures, their functional reserve? Let's stay on the topic of degenerative primary MR. A lot of talk and a lot of interest in surgical approaches to this. So how do you approach the patient? So Frank, have a patient with primary MR. What's your surgical approach?
Midline stenotomy, unashamedly, and I'm interested in the 30-year outcomes, which I discuss with the patient, and it's a perfection operation. So that's what I aim to achieve. I don't think everybody has the same skill sets and technical abilities to do these. And certainly, having had 30 years' experience, I find it works for me. But, the big but, you don't leave the opening and closing to the junior resident. You open and close with the same care and attention to detail that you do the mitral repair. If I do that, my patients do not come back to my clinic complaining about the stenotomy. In fact, many of them say it's just not an issue, and quite a lot have virtually no pain from the start.
And you hit on the key thing. When I've talked to patients, I talk about durability and outcome. So, Rudiger, Frank is full sternotomy. What's the approach in Munich?
Most patients are operated on by minimal access, right thoracotomy. Not all of them, of course, especially we have in Munich, we have set an age limit. Beyond 70 years of age, we would require a CT scan of the whole aorta and see whether there are any calcifications or atherosclerotic lesions, and then we would refrain from minimal invasive access. But other than that, we would go for the minimal invasive access. It involves a training process, of course, a learning curve, and it is a more complicated operation. There's no doubt about it.
Interesting. David, so you've heard two sides here, and I think I know your side, but tell me your side.
Well, it's probably good I'm sitting in the middle because we probably share some of each philosophy. That is that we do small incisions. We do like a midline approach. We usually use a pediatric retractor because we don't want to make an incision so large that we have to put a conventional sort of blade in. On the other hand, I do like antegrade cannulation that takes out the risk of retrograde cannulation, and de-airing is a little more straightforward. So from a safety perspective, it might be a little harder on our backs and necks to come from the front, but from that perspective, we have tended to stick with the midline approach, but through a very limited incision.
Frank?
I just wanted to add, to protect your back and neck, for the last 25 years, I've sat down to do it, and it's a lovely way. Set it up, sit down, and you've got a perfect view.
I mean, so is this what's going on in the world today? I mean, as you look, because I spend a lot of time with patients, and they're talking about once they're convinced that they need surgery, and I've convinced them, then the approach and having the discussion with them, look, I want the best outcome for you, I want durability, but there is increasing talk about minimally invasive approach to this.
Yeah, but interestingly enough, if I look at Germany, the numbers of minimal invasive access procedures has not risen anymore. It's stable at about 47% for the last 3 years now, and it's not rising. And everybody's talking about it, but apparently not everybody's adopting it.
But Rudiger, I think this data from Leipzig that came out, you learn a lot because they have very honest reporting there, and I think this data is suggesting that a minimum of 1 to 2 per week were necessary to prevent complications. This is a very low number of surgeons that can achieve 2 minimally invasive mitral valve operations per week. And you said it, it's harder to do. It takes more skill from the side and more experience. So, yeah, I think that one of the reasons you've seen that curve flatten out is because, there are very few practices like yours that have that kind of volume to maintain that kind of skill.
It's not. Let me just answer to this, Randy. It's not so much the volume. I think you have to create a small team of surgeons who do those operations exclusively, which is, of course, this is devastating for the young surgeons because they don't get much access to the mitral valve anymore.
I mean, that's a very, very important point. I mean, you need dedicated surgeons, and the team is dedicated to have excellent repair. Frank, excuse me.
I just want to add that I think the minimal access is a highly laudable approach. When I discuss it with a patient, the discussion goes something like this. I don't do that. I've not developed the skills, but I can offer you a virtually 100% repair rate with a virtually zero mortality. But I know surgeons who will do this. If you wish to visit them, we'll arrange it.
Right.
And once you start talking about what a midline stenotomy really means, and usually in my outpatients there's 8 or 10 people who already have them, and you point out they're sitting next to them in the waiting room, the whole tension dissipates and the course of conversation changes.
I mean, I think you're right. I mean, again, the emphasis is on outcomes. You really want an excellent outcome. Speaking of outcomes, you taught me a lot about not having the patient leave the OR with any MR once you've done a repair, and I know all the two of you do that. But we do have residual MR. It does recur with excellent repairs. Tyrone, David showed us 1% per year. How do you approach a patient and their referral cardiologist? See the patient back in 1 year, he's got 1+, maybe 2+ MR. What do you say to the patient? What do you say to the doctor, Frank?
Well, first, you're openly honest about it, and if necessary, show the echo to the patient. I think it's a very good place to start. You start from the same ballpark. Secondly, I think you have to approach it as you do at the beginning. And very few of us operate on a patient with mild to moderate MR in the first place. So watchful waiting may well be the right thing in those patients. But you do get the occasional one, all of us do. Rare, where you get moderate to severe MR back for all sorts of reasons. And I think then you have to have an open, honest discussion about what to do next. For me, that is still trying to re-repair, but it may not always be the case.
David, you and I have shared a patient where that occurred.
Yeah. I think that, the key, Randy, gets back again to the degree of MR.
Right.
For mild and even moderate MR, there's something about stabilizing the annulus. Most of these patients will have a recurrent leak based on either scarring and restriction of a leaflet or a recurrent prolapse. But I think the annular stabilization gives them better event-free survival, which is why recurrence of MR is an important probably a better quality marker, but it doesn't correlate. One of the reasons it doesn't correlate with reoperation rates is because these patients are probably stable longer. I think that, you know, the flip side of the coin is that we do a lot of re-repair from around the country in the United States. And when you look at our series, which we reported 2 years ago in Barcelona, and you look at Rakesh Suri's series at Minneapolis or in Mayo, about half the failures, between 40 and 50% of failures, were technical during reoperation. So it's one thing to have a recurrence of MR from progression of disease or scarring. It's another to have a technical failure and residual MR, and I think we have to think a little bit differently about how we manage those two populations.
So looking at the etiology, the reason for the recurrent MR, what about in your hands? What do you do if you have a patient comes back and they've got 1 or 2 plus MR?
First, I absolutely agree with what has been said. I mean, you have to be honest with the patient.
Sure.
And in my experience, I even think that the technical problems are more prominent than the progression of the disease. Now, what is amazing about those patients, and I hear from you that they have the same experience, most of them, even with moderate MR, are asymptomatic. And as long as you do not see a decline in ventricular function or an increase in the left atrial dimensions, I would also be hesitant to jump into the operation.
Excellent point. I mean, you want to look at them on echo and see, you know, can you see a technical failure? But then, you know, we've done in the rare instances I've had it, we've used an exercise stress test and seen no change in their exercise capacity, elevation of right-sided pressures, or any worsening of the MR. Frank, you wanted to say something?
That's a point too. I think longitudinal follow-up as a global patient is terribly important. I was privileged a few years ago to have Barlow spend 6 months with me, and he reviewed 1,000 of my patients. And what he found was a significant amount of uncontrolled hypertension.
Interesting.
And in controlling the hypertension in the mild moderates, the MR got better significantly.
Interesting.
And the other point I'd add is that redos, and I'm getting them now from round about the country, after minimal access surgery is not always easy. The pericardium is usually left unclosed and fallen down by the root of the lung. And getting into these patients can be surprisingly extremely difficult.
Interesting. So let's finish up with degenerative MR here. But let's talk about the tricuspid functional TR in the setting of primary MR. What do you do? How often do you approach it? Rudiger, what do you do? And we're going to get into the rings in just a second. But when do you operate on the tricuspid?
During the last years, we have become more aggressive on the tricuspid, like probably everybody has seen this. So we have adopted this 4 centimeter rule for the annular dilatation, even in cases where you have almost none or only mild tricuspid regurgitation. So in those patients concomitant to the mitral repair, we would also repair the tricuspid valve.
Frank?
Totally agree, and I'm finding I'm doing it more and more and more. Again, I'm concerned that with the minimal access, not true for you, I'm sure, but a lot of surgeons won't touch the tricuspid through minimal access, and yet the whole drift of surgery is to total correction of these. I use the 4 centimeter rule as well, but I do it all before the operation. I think making these decisions on the operating table with an offloaded patient is not a good thing to do.
David? I'm sorry, go ahead, Rudiger.
Just one comment. With the tricuspid, this is really a pathology where the minimal invasive access modifies the indication, I would say. It's not, I mean, you cannot stand up here and say, with a minimal access or median sternotomy, I do the tricuspid in all instances. The surgeons who do minimal access try to avoid the tricuspid because it's much more, that makes the operation even more complicated.
This is why I like this guy. See, it's total transparency. It's
No,
harder to
honest.
get the exposure on the right atrium from the side. But Randy, right now, Joanna Trickley just looked at our latest series of several hundred patients. We're repairing around 65% between 60 and 70% of tricuspids now in the setting of mitral regurgitation, and we've adopted the strategy they've talked about in terms of geometry, not amount of regurgitation. And we also consider these near trigger points, atrial fibrillation, pulmonary hypertension.
Absolutely.
low ejection fraction, patients that are going to be left behind with potential risk factors for progression of tricuspid regurgitation, we'll cheat that number down sometimes if they have other risk factors.
I mean, I think it's an important point. Obviously, Gilles Dreyfus led us in this direction, but I think, I want you to be a little bit more aggressive. I don't want my patient coming back in 5 to 10 years with severe TR with an excellent mitral valve repair. Were you going to say something, Frank?
I was going to say, I agree, it's a horrible situation because when they come back, we know the results. But also, I'd say just a little tip for the surgeon starting out. If the right atrium doesn't look normal, if it's blue and stretched, there's a problem.
Absolutely. So, Frank, you and I haven't invented any, at least I haven't invented any rings, because a wedding ring was the only ring I got. But these two gentlemen have rings. What were you trying to accomplish with the rings you designed? Okay, Rudiger?
Apparently, I'm a big fan of profiled rings to restore the original shape of the valve, and so I favor a stiff ring with a respective profile that restores the anatomy of the tricuspid valve, also in terms of the shape of the ring.
Okay, David?
The ring that we developed, we were trying to go back to our remodeling principle, like Rudiger said. So the free wall part is rigid, but along the membranous septum and where the aortic root bulges, we left that completely flexible so that we weren't forcing geometry in those areas. But again, there's probably a place for 2 different types of rings. I don't know about you guys, but we're using more and more rings and bands for different slight differences in geometry, and we tend to use complete remodeling rings in heart failure patients, and where the operation is for primary TR, and we tend to use these remodeling bands for patients where it's really more prophylactic in terms of the risk of developing TR as opposed to treating severe TR.
Is the type, and I would agree to be very, I think you should be fairly aggressive. The difficulty we have is the echocardiographic measurements, when to measure, where to measure, and I think we'll reach some consensus on this. So, David?
I just want to reemphasize something that Frank said, which I thought was really a good point. And that is that the decisions can't all be made outside the operating room, because when you open up and the right atrium is large and looks like it's pathologically dilated, these are patients I tend to always look at the tricuspid, and oftentimes, regardless of what's been measured or not measured, this surface area of the anterior posterior leaflet looks out of proportion to the amount of dilatation, and vice versa. Sometimes we're told that the annulus is 40, and you look at the right atrium and it's the size of a lemon and completely normal. These are patients that it's hard for me to think need a prophylactic procedure. That may take me away from doing it. So I think this is a really important point to emphasize.
Let's keep on the tricuspid for a second, but in functional MR. So now you've got is the tricuspid problem different in a functional secondary MR patient? Do you have retracted, really restricted leaflets? Do you approach the tricuspid differently in that situation?
No.
Okay.
We would be more aggressive. Well, it's hard for us to get more aggressive, but I would say that the majority of patients with ischemic MR now in our practice are getting tricuspid rings, because most of them do have some remodeling of the RV because they have left-sided failure.
Right.
And I tend to be a little more aggressive based on Calafiore's data, again, sort of suggesting that prophylactic treatment in that group was beneficial.
Same, but I think it's not a one-to-one relationship. And as we know, this is a disease of the distribution of the coronary arteries. So you think about that when you're doing it, and you see a lot of patients with totally normal right-sided right atrial function in ischemic disease with a totally distorted left ventricle. So I think you have to play that one much more by ear and patient-tailored.
So what do we do with functional MR? Are we repairing the valve? Do we replace the mitral? What do we do? Rudiger, what's your approach?
Yeah, I usually attempt to repair it, although there are those discriminative values of anti-systolic volume of more than 65, of the tenting area. If it's more than a centimeter, the height, the results are not very favorable. So in older patients, like in an 80-year-old patient where in whom I do a CABG, I would probably replace the valve right away.
David?
Very selective based on the amount of tethering. For us, we usually do repair, but if valves are very tethered, then we will do adjunct procedures such as cleft closure, chordal cutting, and even primary cord replacement. Just doing a downsized ring is not going to be enough in that 20% or so of patients. And the other point, I would completely agree with Rudiger. There's absolutely nothing wrong with a valve replacement in this population. You know, this report that came out from the Cardiac Network in the United States has generated a lot of discussion, and on both sides, some people saying it shows it doesn't matter, other people saying the recurrent rate with repair was too high. You have to know your own experiences and whether you are comfortable doing some of these adjunct techniques, but there's absolutely nothing wrong with a valve replacement, and that is definitive therapy for most of these patients.
Frank, excuse me, I'm sorry, go ahead.
No, sorry, I just want to add or emphasize what David just said. I think if you repair the functional mitral MR, it's really not enough just to do an undersized ring. You have to work on the leaflets too. So you have to have a ring annuloplasty and work on the leaflets by leaflet augmentation or even by edge-to-edge technique. Some people still do this. Whatever you do, but you have to work on the leaflets.
But now you're really moving into the hands of the masters. I mean, the average surgeon is going to replace the valve, isn't that right? I mean, not have the experience to really do these reparative techniques. Frank, what are your thoughts?
Well, I've had a strategy for a long time, and it goes back to the disease state. If you have reversible recruitable myocardium, which you establish preoperatively by looking for hibernating myocardium with mild, moderate, certainly mild, I won't touch the valve, I revascularize the heart. If it's moderate with revascularizable recruitable myocardium, I'll put a ring in. If it's severe, I'll put a valve in. And I'd like to try and get us to change the terminology from replacement to insertion, because I do think that subvalvular preservation is an important thing to hang on to. I know there's some controversy over that, but I think the work going back to Lily High is pretty powerful.
I can't let it go about differentiating ischemic MR. Posterior infarcts with asymmetric jets, where the majority of the valve is not tethered, is going to do very well, usually with a true downsized rigid ring. And you have to downsize the ring.
So you're talking about a really displaced P3, A3? Okay.
When you have global remodeling and you have tethering across the valve and the entire orifice is involved in the regurgitation process, these patients, I think, if we ever differentiated them and studied them that way, you would find those patients have a very high recurrence rate and likely are better for valve preservation.
And that global disease is going to progress. And although we've got data out to 2 years with a very good published study that we just referred to, 3 to 5 years is the telling time.
Absolutely. So those were simple topics. Let's move to a little bit more difficult topic. Where are we going with the transcatheter approach to mitral valve disease? What do you, if you look out into the future? I mean, we have for the prohibitive risk now in the United States, we have a mitral clip that we can use. We have neocords, we have annular rings, all these things. Rudiger, where do you see us going with transcatheter approach to mitral valve disease?
I think transcatheter replacement will probably take the same way as TAVI did in the past. And as soon as there is a prosthesis on the market that is easy to implant and that fits that accommodates all pathologies, I think there will be transcatheter replacement in most patients. The transcatheter or percutaneous repair devices are, at least at this state, too complicated, and you would have to use several devices to really mimic what we do in surgery. So I think, and since most of these techniques will be used by cardiologists, it will be too complicated for them. So if there is a good replacement device on the market, the patients will get a replacement. I'm pretty sure.
So easy to insert, you said, and can take all types of pathology. Those are big.
The only really important thing is that the surgeons this time don't miss it again.
That's what you underestimate the cardiologist. David, what are your thoughts? I mean, it's great points, though.
I mean, it's going to be a surgical procedure to begin with. It'll be either transatrial or transapical, and then we'll see how that progresses. I'm a little less, and I think it's an incredibly important field that has tremendous promise for a significant number of patients. The overall population one day may be bigger, but it's going to start out much slower. Patients with mitral disease are younger. There's good evidence that valve repair is associated with better survival, and the forces on these transcatheter valves is going to be greater in the systolic position versus the diastolic position of the aortic valve. So when you put all that together, I think there's, the technology is going to require more careful testing. The progression is probably going to be a little bit slower. Populations are going to be a little bit harder to define. The sudden death risk with severe MR is less than the sudden death risk with symptomatic AS. So the pressure on these trials, which patients are going to be studied, is going to be important. Maybe more interesting in ischemic patients. I still think there's a tremendous group of elderly patients with MAC and complex reoperations and patients that you'd probably considered in if you had it. But this is going to be a slow, steady climb. I don't think it's going to happen at the same pace it did on the aortic side.
I have to contradict a little bit. I'm not sure whether the average cardiologist will take all what you just said into account when they decide on the indication. The other point you made is that for right now, you said surgeons are a little bit protected because the access route is from the atrium or from the apex. So this is for now. But we see in TAVI that even patients who have a transapical or a transaortic access, a lot of surgeons just do service to the cardiologist. They provide the access, the cardiologist comes, puts the valve in, and the surgeon closes. So this could also happen with a mitral valve, of course. Surgeons have to get an active role in implantation because
I totally agree with you.
Let me hear from Frank. Complications will be devastating.
Well, I'm not so nihilistic. I think we're going to see what's happened with coronary artery balloon dilatation and stenting. It's going to take off, and as you suggested, it's going to have a big impact. But these prostheses are not great. We know that with the advanced state of prostheses we have now, with the tissue valves, mechanical valves, they still perform less well over a long period of time, which is why mitral valve repair is still there. These percutaneously introduced valves are going to be similar. But there's another factor, and that is patients are very well informed these days. They know what mitral valve repair can do. They'll have the discussion with you about minimal access or open. They're going to really push you over valve replacement. Do I really want a valve, doctor, or can't you repair my valve? So I don't see this as being quite so clear-cut.
I mean, go ahead, David.
Frank, we got to keep in mind that the ischemic MR patient has a limited survival.
I'm talking about general degenerative.
Oh, I understand. Yeah, but I'm saying the populations of ischemic disease as well as the elderly will be the obvious early targets because that will take some of the pressure off long-term performance in the mitral position.
No problem with that, because I think that's quite a bad group for us anyway. But
Rudiger, I think you're totally accurate in that the surgeons really need to be very intimately involved with this whole process, development, deployment. I personally, I've been in this a long time. I personally think that the surgeons ought to be driving this, not the cardiologists. This is a different animal than aortic valve disease, a very different animal. Do you think the surgeons, as you look at your European colleagues, the two of you, are the surgeons migrating toward being very actively involved in this?
No, not at all. And in Germany, we are seeing a development which is unbelievable insofar that the cardiologists have a new position paper. It just came out. And in this position paper, the dogma of having on-site surgery, at least having on-site surgery in the same institution, is not valid anymore. So this opens the way for each and every cath lab in Germany to implant transcatheter valves. So,
Yikes. All right.
In the
Frank?
UK, it's different. There's been a pursuit of TAVI in terms of its development, but Germany really is a special case. The way that your cardiologists have taken this on wholesale is, I think, out with almost anywhere else in the world. I suspect there'll be a balancing act in the future. But the other point that cannot be dismissed at the moment is the cost. And all our healthcare economies are in trouble one way or another. And these are expensive procedures. And as time passes and they're perceived to fail, which I suspect they will be over the 5 to 10 year period, which we've got virtually no data on yet, I remain, as I said earlier, not so nihilistic. I think surgery is going to be there. What we have to do is get better data. We really must get better data, and we must really specify what we're doing in specific specialist valve clinics.
I think that the outcome with the TAVR valves has been pretty good, though. But this is a different valve to insert. Is that what you're saying? You're
Yes,
talking about failure,
it's
not talking about
stresses. It closes under systolic
Right,
pressure.
okay,
It does not close
okay.
under diastolic pressure.
David.
I don't know. I'm not trying to defend surgery or promote transcatheter therapy. I think there's going to be a balance. The best therapies will continue to generate evidence and win. And I think Rudiger is right. Surgery needs to stay involved. And I think you're right, Randy, that the mitral anatomy and the differentiation of disease and the complexity in that landing zone compared to the aortic annulus, I think that it will be important for surgeons to, exercise their knowledge of anatomy to optimize early outcomes.
It's clearly something that is coming, and I think the surgeons have to be intimately involved. Just looking at the complexities of what you guys do with a mitral valve repair, your understanding of the whole apparatus is very important. So we're almost at the end. Any closing comments about what we've said, or any areas that we need to, that you want to feel strongly about? Any comments?
No, I think you have covered it all, and
We've covered a lot.
all questions are answered.
Frank?
Well, I just want to add in this business I touched upon at the end of specialist valve clinics, specialist valve units. One of the problems that we as surgeons have suffered is the wide dissemination of surgical techniques amongst people doing very few of them, and that's damaged our base. I think if we can pursue, it's already happening. You have a wonderful setup. We're trying to do the same thing, and I know really good as well. But if we can concentrate this in specialist cardiology and surgical hands working together, then I think we can find a common pathway which keeps everybody gainfully employed.
Excellent. David?
Yeah, I'd just say I think all the topics we talked about were really relevant, Randy. Mitral valve disease, I think, is going to be the next big focus. That's one of the great things that I am excited about the transcatheter field moving into this arena, because it's going to put a focus on all the topics we've talked about, not just transcatheter therapy. And I think we're doing a lot better job. I actually give my colleagues a lot of credit. I think they're starting to understand targeted referral and the need to pick certain surgeons within their own group to focus on it. And I think the next progression will be more application of guidelines by cardiologists, better imaging, and better decision making. So it's a good day to be talking about mitral valve disease.
The other thing, and Frank, you touched upon this, I think we can't underestimate the world we live in. Education, communication. I think we have to be very innovative in our education. How do we educate, always emphasizing quality, both our colleagues and the consumers, because the consumers are they're really part of the decision tree now. So I think that's very important, and maybe that's what we've done here with this, that we've tried to educate. We hope that you all have enjoyed this, and certainly I've learned a lot, and I hope you have, and we will see you again. Thanks very much.